Hello, I'm Dr. Petros Grivas. I'm a medical oncologist in Seattle. I'm a professor and the clinical director of the GU Cancers program at the University of Washington and Fred Hutchinson Cancer Center. We're very excited to see the rapid and amazing updates in the field of urothelial carcinoma, helping our patients live longer and better through multiple clinical trials. And for context, I want to highlight over the last few years, we had 3 practice-changing trials in the frontline setting of advanced urothelial carcinoma. Currently, the preferred standard of care as per NCCN guidelines includes the combination of enfortumab vedotin and pembrolizumab, EV-pembro, for patients who are treatment naive for metastatic urothelial carcinoma based on the impressive results of the EV-302 clinical trial. Also, of course, we have the data from Checkmate 901 with Gemcis-Nivo being better than Gemcis in terms of PFS and OS. And of course, back in 2020, almost 5 years ago, we had presented the data from the JAVELIN Bladder 100 trial showing that avelumab switch maintenance improves progression-free survival and also overall survival. That was a primary endpoint for patients who had achieved disease control, meaning response or stable disease, to platinum-based chemo with Gemcis or Gemcarbo. Those who went on and received avelumab switch maintenance, they had a longer life and longer PFS compared to those who had observation after response or stable disease to platinum-based chemotherapy in the frontline setting. Of course, over the last 5 years, we have been presenting updates from the JAVELIN Bladder 100 trial, trying to update the data, look at different subsets of patients, we look at potential molecular biomarkers, look at quality of life, relevance, efficacy, and toxicity updates, just to keep informing from these really, really important data sets. And in that context of data updates from the JAVELIN Bladder 100 practice-changing trials, we recently had a paper that was published in the ESMO Open Journal. This was led by my dear friend and colleague, Dr. Shilpa Gupta at Cleveland Clinic and many other colleagues. I was honored to be the senior author in that paper. And what we try to do in that is want to look at long-term outcomes from the JAVELIN Bladder 100 trial, focusing on patients who are more senior in age. And we all know that the median age of bladder cancer diagnosis is 73 years old. So we focus our analysis here in a subset of patients who are 65 years or older, and we want to see how these patients do in the context of the JAVELIN Bladder 100 trial. As I mentioned, this trial showed significant overall survival benefit in all comers as a primary endpoint in patients who had switch maintenance avelumab versus best supportive care alone after response or stable disease to platinum-based chemotherapy. That subset analysis showed that avelumab switch maintenance also prolonged overall survival, also in this subset of patients who were 65 years or older. So this pretty much corresponds, is aligned with the overall trial population in this particular patient subset based on the chronologic age. And of course, we look at toxicity, and there was no new safety signal. There was no new toxicity concern identified in this patient subgroup of 65-year-old or older patients compared to the overall trial population. And we also, pay attention to quality of life. That matters a lot to our patients. And this is an important metric, I think, and important parameter when we discuss with the patients in clinic. And we look at the quality adjusted time without symptoms of cancer or toxicity side effects. And this was about approximately 5 months longer with avelumab versus best supportive care alone. That may reflect the progression-free survival benefit with avelumab and the overall, I would say, tolerable toxicity profile with a single agent checkpoint inhibitor, as opposed, of course, to other cytotoxic agents. So overall, to conclude, our analysis in the ESMO Open paper pretty much confirmed with a longer follow-up. There is an overall survival benefit and, of course, PFS benefit with avelumab switch maintenance versus best supportive care alone in all subgroups of patients, including patients who are 65 years or old or older. And the important, I would say, parameter is that this treatment seems to be well tolerated. There was no new safety concern. So this is an important option for patients who had already received platinum-based chemotherapy, have disease control, and patients who meet the criteria from that particular therapy scenario. Of course, the limitations include that as we look at the different subsets, the sample size may be smaller as we look at particularly patients who were like more than 75 or more than 80 years old. Those subsets were probably a smaller proportion compared to the overall trial population. And of course, this was an exploratory subset analysis, but this seems to be to me that the benefit with avelumab seems to be across the board, with different degrees of benefit, of course, different degrees, magnitudes of benefit, but seems to be consistent across the board for those trial subsets of patients. And as I mentioned, we look at the quality of life as well, and this data suggests that there seems to be some quality of life benefit in those patients, maybe reflecting the progression-free survival benefit and the toxicity profile of these drugs. We're committed to continuing supporting patients and informing them of updates from different clinical trials. So that paper, again, reflects that desire to keep looking at the data with longer follow-up and look, of course, at patient populations. As we know, the population is aging. So looking at this, population of more senior patients, I think is clinically relevant in the literature. So thank you so much for your attention, and thank you so much for all you're doing to take care of the patients. Have a great day.